Call upon Dr. Natasha, madam. She needs no introduction. The full hall says it all.
That's
Okay,
not
she'll be
me.
talking on diabetic macular edema.
I think this is the most accessible hall probably. Just everybody just walked in. So this is after the two relatively rare cases, we go to the most common case that we see in our medical retina OP, which is diabetic macular edema. So I'm just going to present two cases and then we'll jump into the discussion. So this case is a both eye severe NPDR with diabetic macular edema presented to me with 618 vision in the left eye. He was the uncle of the colleague of the hospital where I'm going. So I advised him the high-end intravitreal injections and he decided on brolucimab. So I was very pleased because he's going to get a good result is what I thought. But after 4 injections of brolucimab, this is his macular edema on the other side. His vision has just improved from 618 to 612 parts and I was left feeling like a little bit of a fool. And due to the lack of response to brolucimab and also because of the development of cataract, then I advised thought of switching to the steroid group and combining a cataract surgery. My aim was to give him a little bit increase in vision. So let's put in some Ozurdex and let us send him for a cataract extraction. So I sent for that and the edema had decreased some extent and the patient was taken up for cataract surgery and was good after cataract surgery. But immediately as the Ozurdex effect went off, the edema came back. Now this time he didn't want repeat Ozurdex, he didn't want brolucimab, he said already I've spent too much money, I don't want any of that, I want the lower anti-VEGF, and he chose a biosimilar. And 4 injections of biosimilar later, he is still at his macular edema, you can see it is still up there and his vision is at 612. So that is one patient. This patient came to me with PDR with a very mild edema. I advised him an angiogram, but by the time he came for the angiogram, his edema had increased. So I advised him injection followed by cataract surgery, followed by a PRP. And after the first injection, ranibizumab, and post he underwent cataract surgery, edema had decreased, underwent cataract surgery, very happy, his vision was good. I gave him a first sitting of PRP and then the edema came back like this. 2 weeks later he calls me saying, ഭയങ്കര ബ്ലറിങ് സാർ മാഡം എനിക്കൊന്നും കാണുന്നില്ല ആൻഡ് വെരി വെരി അൺഹാപ്പി ആൻഡ് സോ ഐ അഡ്വൈസ്ഡ് എ റീ ഇഞ്ചക്ഷൻ ഐ ഹാഡ് ഓൾറെഡി ടോൾഡ് ഹിം ദാറ്റ് ഇറ്റ് മൈറ്റ് ബി റിക്വയർഡ് ബട്ട് ഇറ്റ് വാസ് വെരി മൈൽഡ് edema. First injection it went off, so I didn't really give him a very grave prognosis that he will require a lot of injections or anything. And then he was very unhappy and you can guess what he did. So he went to another hospital and so that's what happened. So this is what often happens to us. So one term that we should know is refractory macular edema is when your injections have not given you more than 5-letter improvement or a less than 10% decrease in the CST. Lack of treatment response when you have given 3 anti-VEGFs and there is persisting or worsening of DME and non-improvement of functional and anatomical outcomes. Now what affects the treatment response? The better the baseline characteristics, the better the response. Baseline visual acuity, age of the patient, chronicity of the edema, absence of ERMs, the grade of the diabetic retinopathy, more CNP areas means more contribution to the macular edema. Vitrectomized eyes and associated systemic status. We also know OCT biomarkers can help us predict. The ones that help our SMD responds very nicely, vision will improve. Integrity of the ISOS and the external limiting membrane, if it is there, it will improve. The high reflective foci, if they are lesser, it will improve. And drill, if it is there, higher the drill, lesser the improvement. And presence of any vitreoretinal interactions can cause a decrease in the effect. But all of this are just studies and they're not predictive in a single patient who comes to you in your OP. Now, how do you manage a refractory DME? You have to correct the systemic factors. You can change the class of the anti-VEGF, advise a different anti-VEGF. You can change to a steroid. And so for my discussion with you, I would like to consider these questions. In your practice, when do you consider switching of the intravitreal agent? Do you do it after the first injection, second injection, third injection, or you just give up? Just give me your response. Do you do 1, 2, or 3? 2 injections, madam. PSG madam says 2 injections. Anybody else? In diabetic macular edema, what do you expect to happen after 1 injection? 5-letter improvement in after 1 injection. Yeah, about 100 micron decrease in the edema, and about a 5-letter improvement, maybe just a 1/2 line improvement in your Snellen acuity. But so generally, the refractory DME definition is 3 injections of anti-VEGF. So you can wait for 3, and if you are absolutely sure it's not budging at all after the first and second injection, then you can shift in the second injection itself. The second one is, how good control of systemic factors do you need for starting treatment? Do you wait for the HbA1c? So I have staff calling me and saying, "Ayyo, madam, naala injection vechirikkuva patient HbA1c 9." So HbA1c 9 inject cheyo. Yes, it is only a day-to-day control of sugars that we require. We should have a fasting sugar less than 150 preferably, and a ppbs less than 250 before taking up for injection. It is not required to get the HbA1c under 7 for you to start treatment for DME. It's never going to happen. So your day-to-day sugars should be controlled. Fasting sugar should be controlled when you take up for injection to prevent the infection risk. It really does not have much action on the result of the injection. But when do you say that, okay, I'm going to wait for systemic control, I'm not injecting this patient? When you have bilateral SMDs, a recent worsening of vision, a patient says that he has been admitted in the hospital for some surgery or for a foot infection, something that has recently worsened his systemic status. There, your patient has come with the increase in the edema, severe macular edema with some SMDs. If you have submacular detachment bilaterally associated with some systemic status worsening, it is worth waiting for a month to get that under control. Send a letter to the physician saying that he has worsening of his macular edema. A worsening renal function again can cause. But you don't have to wait for more than 1 month. There is no contraindication for injection, but recent worsening in the vision with a recent history of a systemic admission for some aggravating factor of his diabetes, it is worth waiting for 1 or 2 months till that gets controlled. It actually reduces just by the control of the systemic factors alone. Anything else that you have found in DME management? One is to look for pioglitazone in the number of drugs they are using, but very rarely they use it now. So, and the other thing is, with the trade names, you really don't know which is the pioglitazone in that anyway. So that is a very difficult thing to find out. But anything else? Anybody in the audience has anything to share?
One thing which causes worsening of DME is this blood sugar when they go in for hypoglycemia and then hyperglycemia.
The brittle blood sugar.
Brittle blood sugar. If it is little higher blood sugar, if they are like 150, 160, that has better prognosis than having one day they're having 70 and next day they're having 150. That causes more macular edema and more this thing. So that we have to discuss with the physician and ask them to reduce their insulin dosage.
The last question, I think we are bang on time. Last question, how many of you are using the newer anti-VEGFs, aflibercept and Vabysmo, faricimab? Hands up, please. Yes, Simi. Yes, ma'am. What is your experience with the newer anti-VEGFs? No commercial interest here. It's just a discussion because people should be aware of the newer anti-VEGFs. Ma'am, what is your experience, ma'am? Have you got a good result? How do you feel that it improves our results? Edema-free intervals, yeah. So that is something I want to introduce, that everyone should start using higher anti-VEGFs in higher means higher cost anti-VEGFs in patients who can afford it, because it has really changed the management of DME, at least in my practice. I don't know if any Roche person is here. He should be at home with some flowers by now. But no, this is no commercial interest. But with the advent of the new drug faricimab, and also with our older drugs that we had, aflibercept, switching from ranibizumab to these higher agents definitely gives a good result in DME, and we get a very large interval of time before giving your re-injection. You have to still advise re-injections, but definite differences there, I would say, especially with the latest entrant into the group, which is faricimab. So that is all I wanted to say. Any doubts, any questions? Faricimab approximately costs around, to the patient, around 75,000. Varies between 75 and 80 between hospitals. But they give 1+1, so the next one you can charge just the procedure fee. So in Chaitanya, we have 77 to start with, and then only 5,000 for the next injection. So thank you all for the physician fitness before the anti-VEGF. I think it entirely depends on your practice. In a multi-specialty hospital, unless the patient has a definite cardiac stroke or liver problems or a foot infection, we did not take in Amrita. But now that I've shifted to primarily eye hospitals, I take a physician fitness. That is just to be safe. In case something goes wrong, patient develops something, then just to be safe, that's all. So depends on your practice. If you're practicing in eye hospital, I would advise you to have a friendly physician to whom you can send your fitness. But the problem with sending for a physician fitness is that most physicians do not know what fitness they should give. So do you need the HbA1c down to 7? So in your fitness letter, it is better to say that I would like the sugar to be under control. If you're suspecting a foot infection, you can write that I would like to see that there is no infection in the foot. Angane specific you will get a better response from the physician. And I also add in my fitness paper that there is no requirement to stop antiplatelets for this procedure, because that is the next thing they'll say, "You aspirin nirthan pattathilla." We don't need aspirin to be stopped. So that you can convey to the physician. Okay, I think with that we'll wind up the session, and I'll not stop you from lunch. Thank you all for being here.